Hello, and welcome to today's webinar, Updates from ASCO. A few housekeeping notes before we begin. All participant lines will remain muted for the duration of our webinar, and questions will be taken at the end of the presentation. To ask a question, please utilize the chat box within the webinar tool. Dr. Mose, you may now begin today's presentation.
Thank you for the intro, Molly. Joe and I have been looking forward to presenting updates from the American Society of Clinical Oncology, or ASCO, annual meeting as the final webinar in this series. The annual meeting takes place in Chicago every year in early June and is attended by close to 40,000 people from around the world. The theme of this year's meeting was Collective Wisdom, the Future of Patient-Centered Care and Research, and approximately 2,200 abstracts were presented on all types of cancer, encompassing all treatment modalities, supportive care, survivorship, and prevention. Here are our disclosures, and we would also like to disclose that data related to the use of medications that are investigational and not yet approved by the FDA may be discussed today. Here are just a list of abbreviations you can refer to as we go through the information. Some of the abbreviations will also be on the slides themselves. Our objectives are listed here. We will interpret research findings of key abstracts expected to impact clinical practice and treatment strategies in hematology oncology. We will evaluate new interventions in supportive care for their potential to help with therapy-related side effects and patient adherence as well as tolerance of therapy. And lastly, we will assess new information on the pharmacokinetics, pharmacodynamics, or clinical management of oncology therapy-related medications. The first half of the presentation will be presented by myself and focus on updates in the treatments of various cancers. The second half of the presentation, Joe will take over and present updates in supportive care. There were many practice-changing abstracts presented this year, and for treatment updates, the abstracts I selected will, 1, give us a picture of where we're at with immunotherapy, 2, focus on treating solid tumors that have limited treatment options and maybe yet weren't covered in previous webinars, and 3, lastly, bring you data that will impact your practice. Immunotherapy was named by ASCO as the Cancer Advance of the Year. It is here to stay, and the status of cancer immunotherapy is this. We have a variety of effective approaches, most of us being familiar with CTLA-4, PD-1, and PD-L1 inhibitors. We have seen CAR T cells and oncolytic viruses emerge with much success as well. But there tend to still be a vast majority of patients who do not respond to single-agent checkpoint blockade. And we continue to have a lack of clear predictive biomarkers of response. We have seen some encouraging reports of combination therapy of immunotherapy. However, this has been met with increased toxicities. So why is it that patients or certain tumors do not respond to single-agent therapy? And then what is the rationale for some future combination therapies? This slide here kind of sets up the biology behind that rationale for combination therapies. And currently we know when a tumor forms, a T cell response occurs at the same time with the hope of eliminating that tumor. And we know that the tumor has developed ways to evade or escape this immune response through either an immunoediting process where it develops resistance to therapies, or by creating an immune-suppressed environment around it that we've learned to overcome with CTLA-4 or PD-1 antibodies. Down at the bottom here, we have now learned that some tumors have what we call sort of an innate state of immune suppression, where they don't have any T cells available, and thus no T cell response occurs. So we have now an immune-privileged tumor that doesn't need a mechanism of escape. These tumors that don't have any T cell response or T cells available have been termed cold tumors, whereas tumors that have a T cell response have been termed hot tumors. And the challenge presented is this: are we able to then convert a cold tumor to a hot tumor through different combinations of immune therapy? That brings us to our first abstract, Abstract 100, presented by Dr. Antonia from the H. Lee Moffitt Cancer Center in Florida. He presented the results of Checkmate 032, which looked at nivolumab alone or in combination with ipilimumab for the treatment of recurrent small cell lung cancer. Patients with small cell lung cancer, we know, frequently respond to first-line chemotherapy. However, recurrence is the rule, and unfortunately, outcomes with second-line treatments are very poor. Immunotherapy agents have been explored in patients with small cell lung cancer, but small cell lung cancer is an example of a cold tumor with relatively few numbers of tumor-infiltrating lymphocytes in small cell tumors, thus limiting the efficacy of single-agent nivolumab. The thought is adding ipilimumab, which has activity within the lymphoid compartment, results in an increased number of tumor-reactive T cells that now are available to function in the presence of nivolumab within the tumor microenvironment, thus overcoming this immune-suppressed state. The Checkmate 032 study was a multi-center open-label phase 1-2 trial that included patients with small cell lung cancer who had progressive disease after one or more prior lines of therapy, including a first-line platinum-based regimen. Patients were randomized to 3 treatment arms, as you can see here, nivolumab alone and 2 different dosing schemes of nivolumab in combination with ipilimumab. Combination treatment was given every 3 weeks for 4 cycles, and then patients continued on nivolumab alone. You can see baseline patient characteristics here, and what I want to call your attention to is that in the small cell lung cancer population, down at the bottom, tumor PD-L1 expression levels were absent in more than 75% of patients in all 3 treatment arms. This table lists treatment-related adverse effects that we saw occur in the study, and as to be expected, we see higher rates of adverse effects overall with the combination therapies, with more than 70% of patients experiencing any grade toxicity in the combination arms versus 53% in the nivolumab alone arm. Looking down at the bottom here, we see 7 to 11% of patients in the combination cohorts discontinued due to toxicities, and there were 3 treatment-related deaths, all in the combination therapy arm. If we look specifically at grade 3, 4 toxicities in the combination arms, we actually would see a lower incidence here with this combination in small cell lung cancer than we've seen in other tumor types like melanoma or non-small cell lung cancer at these same doses. So again, this kind of relates back to the immune-suppressed state of small cell lung cancer, with the biology now of the tumor microenvironment leading to differences not only in efficacy, but also tolerability of immunotherapies in combination. Response rate was the primary endpoint of this trial, and we see that response rates were doubled with the combination of nivolumab and ipilimumab versus nivolumab alone. We saw the highest response rate with the nivolumab 1 mg per kg, ipilimumab 3 mg per kg dosing arm. Overall, they were durable objective responses, and responses occurred regardless of platinum sensitivity or tumor PD-L1 expression. Overall survival data is still early, but we are seeing a survival advantage for the N1 IPI3 combination arm. And this combination was the one selected then for the ongoing phase 3 trial. And as we see with immunotherapy in other disease states, the tail of the overall survival curves is being sustained above the x-axis for the combination arms. In conclusion, we see that the combination of nivolumab and ipilimumab provided durable objective responses in patients with relapsed small cell lung cancer with encouraging survival results as well. We saw safety profiles similar to what we see in other diseases. And then, as I mentioned before, the nivolumab 1 mg per kg arm plus the ipilimumab 3 mg per kg arm is the regimen selected for phase 3 study. As far as how this abstract will impact your practice, I think a takeaway message is that we really don't have a one-size-fits-all approach yet to dosing immunotherapies in combination, especially as we go from one tumor type to another. And we have learned that cold tumors may influence how well tolerated immunotherapies are in combination. At the conclusion of this abstract, when I heard it, I would have said that this combination was maybe not yet ready for prime time. I think we still need to glean some data from phase 3 trials. However, I will note to you all that NCCN guidelines have been updated to include this combination as a second-line therapy treatment option. Continuing with the theme then of immunotherapy in difficult-to-treat diseases, we'll look at abstract 6009 presented by Dr. Ferris out of the University of Pittsburgh. And this was the Checkmate 141 trial that looked at further evaluations of nivolumab versus the investigator's choice chemotherapy for recurrent or metastatic squamous cell carcinoma of the head and neck. The Checkmate 141 study was a randomized global phase 3 trial that randomized patients in a 2-to-1 fashion to nivolumab alone or to the investigator's choice chemotherapy, where choices included methotrexate weekly, docetaxel weekly, and cetuximab weekly. The primary endpoint was overall survival, and patients were included if they had recurrent or metastatic squamous cell carcinoma of the head and neck that had progressed on or within 6 months of the last dose of platinum-based therapy. So progression could have occurred in the locally advanced, adjuvant, or in the metastatic setting. So overall, this was a study of a patient population that has a very poor prognosis, having failed a platinum therapy. They did document HPV status through a surrogate marker of P16, in particular patients that had oropharyngeal cancer. And then patients were included regardless also of PD-L1 status. Not all demographic and treatment data are included in this table, but I did want to pull out just pertinent details. Overall, the treatment groups were evenly matched. If you look at HPV status here, you can see that 25% of patients were HPV positive, and this was balanced between both treatment arms. And again, that was marked by P16 as a surrogate for HPV status. You can see the breakdown here in the investigator's choice chemotherapy treatment arm, with most of the patients receiving methotrexate or docetaxel. 17.4% of patients were still on treatment with nivolumab at the time of the interim analysis versus 2.7% of patients in the investigator's choice arm. The study was stopped early at a pre-planned interim analysis, which showed overall survival to be statistically significantly longer in the nivolumab arm at 7.5 months versus the investigator's choice arm at 5.1 months. The hazard ratio was 0.7, leading to a 30% reduction in the risk of death with nivolumab. Drawing your attention down further, we look at progression-free survival, and we see that there was no difference between the two groups. And this is consistent with immunotherapy data that we see in other disease states as well. We often see improved overall survival, but not necessarily progression-free survival. Also keep in mind this was an interim analysis, so we may see a difference with longer follow-up as responses can tend to occur later. And looking at responses so far, we see that the response rate has doubled in the nivolumab arm versus investigator's choice. This slide here shows overall survival by tumor P16 status and PD-L1 expression. And the takeaway message from this slide is that the hazard ratios for overall survival favored nivolumab for all of the subgroups, whether PD-L1 positive, PD-L1 negative, P16 positive, or P16 negative. We can note that the magnitude of overall survival benefit of nivolumab was greater in patients with tumor PD-L1 expression. However, keep in mind the numbers are small, so it's really difficult to make conclusions based on P16 or PD-L1 status at this time. It's interesting to observe in terms of adverse effects that patients tolerated nivolumab better than they did in the investigator's choice arm, with about 60% of patients experiencing any grade side effects in the nivolumab arm versus close to 80% in the investigator's choice arm. Patient-reported outcomes were also extensively studied using the EORTC Quality of Life Questionnaire. There were many outcomes reported, but I selected the one down here on physical function to include here to show that nivolumab actually stabilized patient-reported outcomes, while the investigator's choice led to meaningful declines in function and worsening of symptoms. So in conclusion, nivolumab was the first to demonstrate improved overall survival in this patient population after failing platinum-based therapy. Again, we saw the survival benefit regardless of PD-L1 expression or P16 status, and we saw that patients tolerated nivolumab better and stabilized patient-reported outcomes. As far as how this abstract will impact your practice, I think we can acknowledge that nivolumab is emerging as a new standard of care option for patients with recurrent or metastatic squamous cell carcinoma of the head and neck after platinum-based therapy. I think the study design was robust, and we do have overall survival data. Keep in mind that PDL expression continues to be a robust biomarker, but still imperfect in predicting who benefits from therapy. We will now shift gears a little bit and talk about some exciting data for multiple myeloma. I know multiple myeloma was maybe covered in one of the previous webinars, but this data was really too good to pass up. Abstract LBA4 was selected as one of the 4 plenary sessions for the 2016 meeting, and Dr. Antonio Palumbo presented the results from the Kastorf Study, which is a phase 3 randomized controlled study of daratumumab, bortezomib, and dexamethasone versus bortezomib and dexamethasone in patients with relapsed or refractory multiple myeloma. Briefly, we will just review the single-agent activity of daratumumab, for which it is FDA approved for relapsed or refractory multiple myeloma after at least 3 prior lines of therapy. In this heavily pretreated myeloma patient population, it demonstrated a significant response rate of 31% and a median overall survival of 20.1 months. So the Kastorf study was really looking now at daratumumab being used in combination with other agents and also looking at moving it earlier into the line of therapies. It was a multi-center randomized open-label active controlled phase 3 study that included patients with relapsed or refractory multiple myeloma. Patients were included if they had just 1 or more prior line of treatment, and patients could also have received bortezomib but could not be refractory to it. Patients are randomized to one of 2 treatment arms. One had daratumumab given in combination with bortezomib and dexamethasone, and the other arm was bortezomib and dexamethasone alone. Daratumumab was dosed at 16 milligrams per kilogram every week for the first 3 cycles, every 3 weeks for cycles 4 through 8, and every 4 weeks for cycle 9 and beyond. Bortezomib in both treatment arms was given subcutaneously at the standard twice-weekly dose of 1.3 milligrams per meter squared. You can see the dexamethasone dosing listed there. Bortezomib and dexamethasone were given for 8 cycles, repeated every 21 days. And the primary endpoint was progression-free survival. Baseline demographics are shown here, and I would just like to highlight on the right-hand side that about half of patients had only received 1 prior line of therapy. The majority of patients had received prior transplant, prior proteasome inhibitor therapy, and or prior IMiD therapy. Getting right into the results here of the Kastorf trial, we'll start with overall response rate, and we see that it was significantly improved in the combination with daratumumab. In particular, looking at complete responses, we see a doubling of the complete response rate. More importantly, looking at the primary endpoint of progression-free survival, we see that median progression-free survival was not yet reached in the DVD arm versus 7.2 months in the VD arm. The hazard ratio was 0.39, resulting in a 61% reduction in the risk of disease progression or death. This hazard ratio was described by the presenter and author as being truly unprecedented in the treatment of relapsed or refractory multiple myeloma. Looking at progression-free survival across various subgroups, the takeaway message is this: incorporating daratumumab earlier on may be more beneficial. In particular, looking at patients that had ISS stage 1 disease, 1 prior line of therapy, and no prior bortezomib, the advantage was very significant, as indicated by their hazard ratios. In terms of adverse effects, we did see an increase in the number of patients who had thrombocytopenia and peripheral neuropathy in the combination with daratumumab. However, this wasn't necessarily attributed to daratumumab itself, but more due to the fact that patients were on therapy longer in this combination. Looking down at grade 3-4 toxicities, we see again those cytopenias listed there. Hypertension was also listed, and this was more due to the infusion of daratumumab at its max rate of 200 mils per hour. Peripheral neuropathy is a concern as well. We do have to acknowledge daratumumab infusion-related reactions. Overall, they occurred in 45% of patients, but most of them were low grade and occurred on the first infusion. This last slide here is again just to emphasize the significance of this study's results. It is a cross-comparison of hazard ratios across different studies with similar treatment comparator arms. Of course, we have to take caution as these are different studies and have different inclusion criteria for their patient populations, but it's worth highlighting how deep the hazard ratio is with daratumumab in combination with bortezomib and dexamethasone versus other combinations recently studied. So in conclusion, the combination of daratumumab with bortezomib and dexamethasone significantly improved progression-free survival and response rate in comparison with bortezomib and dex alone. This translated to a 61% reduction in the risk of progression, disease progression or death. Again, we saw treatment benefit across all subgroups, but taking away that earlier treatment may be most beneficial. And we did not see any additive cumulative toxicities by adding daratumumab. Impact on practice, I think we will see this combination of daratumumab with bortezomib and dex potentially be a new standard of care for relapsed or refractory multiple myeloma after even just one prior line of therapy. As a side note, there have been further results that looked at the results of the POLLUX trial that were presented at the European Hematology Association 21st Congress shortly after this. The POLLUX trial was a similar study design that looked at the combination of daratumumab in combination with lenalidomide and dexamethasone. And we saw similar results produced, I think confirming that earlier use of daratumumab is beneficial. As pharmacists, I think we need to consider the bortezomib and dexamethasone dose and schedule that was studied in this trial versus what we are currently seeing in clinical practice. I think one question is, will we ever see the bortezomib dosing be modified to weekly dosing, and would the outcome be the same? We now have our first audience response question. Up at the top right-hand corner is where you can cast your vote for which answer you think is best. And the poll is open. As I read the question here, in the Kastorf study, the one we just covered, which three subgroups of patients obtain greatest benefit in progression-free survival? Give you a little bit of time here to answer. Your choices are A, age greater than 65 with stage 3 disease and prior bortezomib, B, stage 3 disease, greater than 3 prior lines of treatment, no prior bortezomib, C, stage 1 disease, 1 prior line of treatment, no prior bortezomib, and D, age greater than 65, stage 1 disease, and prior bortezomib. Okay, it looks like the majority of you got the answer correct. Yes, the answer is C, stage 1 disease, 1 prior line of treatment, or no prior bortezomib. Those were the three subgroups that had the greatest benefit in progression-free survival. All right, the last abstract we will cover is the abstract LDA 4006, termed the SPAC4 trial. This was a multi-center international open-label randomized controlled phase 3 trial of adjuvant combination chemotherapy of gemcitabine and capecitabine versus monotherapy gemcitabine in patients with resected pancreatic adenocarcinoma. The SPAC trials are a series of trials evaluating adjuvant treatment of pancreatic cancer. And so far we've learned that either 5-fluorouracil or gemcitabine are both rational adjuvant regimens to treat patients who have had resected pancreatic cancers with no difference in overall survival between them. So why not combine them? We've seen the combination effective in the metastatic setting with improved response rates and progression-free survival. So the SPAC4 study included patients who had complete macroscopic resection for pancreatic ductal adenocarcinoma. The resection had to be either R0 or R1. They could have no additional metastatic disease. They had to have good performance status and a life expectancy greater than 3 months. They were randomized to one of two treatment arms, either gemcitabine alone at 1,000 milligrams per meter squared given on days 1, 8, and 15 every 28 days for 6 cycles, or the same dose of gemcitabine in combination with capecitabine dosed at 1,660 milligrams per meter squared per day for 21 days or 3 weeks on of a 28-day cycle. And the patients also received 6 cycles. The primary endpoint was overall survival. Again, looking at just a few select patient demographics between the study groups here, we see that the majority of patients had R1 resections, the majority of patients had moderate or poor grade tumors, and the majority of patients had node-positive disease. So this was a very real-world patient population and had very poor prognostic patients compared to other studies in the adjuvant setting. I'd also like to call your attention to post-op CA19-9 levels, which had no limit for enrollment, as you can tell by the upper end of the ranges there, which was different from other studies as well. So this study likely included patients who probably had low-volume metastatic disease. The trial was stopped early because the primary endpoint was reached. The combination of gemcitabine with capecitabine significantly improved overall survival versus gemcitabine alone. You can see overall survival in the combination was 28 months versus 25.5 months in the gemcitabine alone arm. And the survival curves really begin to separate at around the 2-year mark. Looking at adverse effects, this table here highlights grade 3-4 toxicities, and in the GEM-CAP arm, we saw significantly more grade 3-4 diarrhea, neutropenia, and hand-foot syndrome, which would be expected with the addition of capecitabine. But I think more importantly, looking down at the bottom here, there was actually no difference in patient-reported treatment-related adverse effects between the two groups. So that tells us that side effects were managed well. This slide here shows us a summary then of all of the SPAC trials so far evaluating adjuvant treatment in terms of 5-year overall survival. And you can see that the combination of gemcitabine and capecitabine at the bottom has almost doubled the 5-year overall survival rate. So in conclusion, we saw overall survival significantly better with the combination of gemcitabine and capecitabine versus gemcitabine alone. And we saw estimated 5-year survival rates with the combination superior to gemcitabine and all of the previous SPAC trial arms. We do see more toxicity with the combination, but it appears to be manageable. This one is a practice-changing abstract. Adjuvant treatment with the combination of gemcitabine and capecitabine is the new standard of care for resected pancreatic cancer. I think one question we're left unknown is as we see more neoadjuvant treatment of potentially resectable pancreatic cancers, patients being exposed to 5-fluorouracil in the neoadjuvant setting, we don't know how that would impact survival results with adjuvant gemcitabine and capecitabine. I think we also need to consider that this was a European patient population, especially when looking at how well patients tolerated capecitabine. And also consider that this is the first time we're seeing capecitabine being dosed for 3 weeks in a row with 1 week off. I think with this regimen, there truly is a role for the oncology pharmacist in help managing adverse effects, as well as adherence complexities with the combination of IV and oral chemotherapy in this regimen. So those are the abstracts I will cover in detail. The last slide here, we kind of put together a few tweets from ASCO. Both Joe and myself, we just highlighted a few of the abstracts that I think are worth noting, but we don't have time to go into detail. And I'm probably over my character limit in the true tweet world with these. But just looking at LDA1, abstract LDA1, that looked at extending aromatase inhibitor therapy beyond the standard 5 years out to 10 years in postmenopausal women. In early breast cancer, we saw improved disease-free survival. Looking at abstract 5008, patients with metastatic castrate-resistant prostate cancer, they compared 2 doses of cabazitaxel, so 20 milligrams per meter squared, which is lower than the current FDA-approved dose of 25 milligrams per meter squared. They found that it was non-inferior in terms of overall survival, and patients tolerated it better. Lastly, I'd like you to look at abstract 4506, where we heard results from a second interim analysis of the METEOR trial that showed us cabozantinib does improve overall survival in patients previously treated with advanced renal cell carcinoma. And now I will turn it over to Joe, who will present updates in supportive care from the ASCO annual meeting.
Thank you, Jocelyn. So the focus here, when we're referring to supportive care, is side effects, medication management, adherence, drug interactions, and other things that we can do to make therapy tolerable to the patient as they move through it in our hope for a cure. Is it of interest to pharmacists? I said to myself as I looked at all these posters. More importantly, does it support the patient? Does it clarify or confirm a current practice? Does it provide new information or expand the practice that we're already doing? Or does it solve something that's a common clinical dilemma that really has not been well explained? The other thing is I went through these posters where is there a confounder that is so significant that it makes the information questionable? And even in a large meeting like ASCO, it's surprising how often you find these. Our first poster is of vincristine co-administration with fluconazole during pediatric ALL induction. This is a single-center retrospective review looking at inductions in age 0 to 18 for 10 years. And they ended up with 197 patients, 160 or 81% that had fluconazole and 37 that had not. Toxicity was greater in the fluconazole group that was recorded. However, when you look at doses actually adjusted for toxicity, there was no difference between the groups. This is a relatively young population with a mean age of 6.2 years, and 76%, so 3/4, were actually under the age of 10. 40% female, a little over half Caucasian, primarily B-cell, and more prednisone being used than dexamethasone. The patient characteristics and whether and if you look at them, the percent with vincristine toxicity, fluconazole 26% versus 19%, which is not huge, but it's certainly there. The biggest thing that came out of this study was that the breakpoint is around the age of 10. Over the age of 10 saw much more toxicity than under the age of the 10. And while this was a smaller population, it was pretty clear from what we saw. The other really interesting finding was that African American, in general, had less vincristine toxicity. When speaking with the study author, it turns out that most African Americans, or African Americans more commonly, have an extra copy of 3A4, CYP3A4, 3A5, and this may be protective actually from the vincristine toxicity in that they metabolize it more quickly. So my discussion points from this poster is 1, over the age of 10, more toxicity than under 10. So 10 is now old for a child. However, if you think about this, can we extrapolate this to adults? And so all of our adults are going to be, if we do that, at higher risk for azole vincristine interaction toxicity. While there was more toxicity seen, is it significant toxicity when we see that there weren't actual dose adjustments by arm? So, and then the duration of toxicity was unclear, whether this is something that stuck with them post-cure or if it was relatively slow. So I know at our center we actually don't add azoles to induction because of our concern for vincristine toxicity. And this probably supports that, but we certainly need more clarification around it. Our next poster is a double-blind phase 2 of olanzapine 10 milligram versus 5 milligram for highly immunogenic chemotherapy with cisplatin. These are adults with solid tumors. The cisplatin dose was greater than or equal to 50 per meter squared. Standard aprepitant dosing with oral drug, 125 milligram on day 1, 80 milligrams on days 2 and 3. This is a Japanese study, so the palonosetron dose was 0.75 milligram instead of the standard 0.25 milligram that we're used to in the U.S. And then the normal dexamethasone reduced dose on day 1, 8 milligrams on days 2 through 4. And then they were randomized to either 5 or 10 milligrams of olanzapine starting on the first day. Primary endpoint was complete response in the delayed phase with no analysis, no rescue, days 2 through 5. Response on day 1, complete control, which is CR plus minimal or mild nausea, time to treatment failure, and side effects were secondary endpoints. So when we look here, we had 76 patients in 10 milligrams, 77 in 5 milligram groups. No difference between groups in age, ECOG status, tumor type, or the number that were chemo naive when we look at patient demographics. Mean cisplatin dose was 72 milligram per meter squared, and so really respectable doses. In the delayed phase, our primary endpoint, there was no difference. And in fact, the 5 milligram was numerically a little better. Similar when you look at complete control in the first 24 hours and versus days 2 through 5, and time to treatment failure, there was no difference. Side effect-wise, there was more somnolence in the 10 milligrams for the first 3 days. On the 4th day, the two curves actually crossed over. So with the more recent New England Journal paper and wider use of olanzapine overall, I think the 5 milligram offers a wider use with better tolerability, especially if we're moving it into the front line. However, this was a Japanese population. The other antiemetic doses were slightly different. Do we need a confirmation in a different ethnic group? And I think that probably is true. As far as next poster, dexamethasone for chemoembolization side effects. This is 120 patients with hepatocellular cancer randomized to granisetron with placebo or granisetron with dexamethasone on day 1 as well as days 2 and 3 afterwards. Demographically well-matched groups. The primary endpoints we're looking at fever, nausea and vomiting, anorexia on day 1, and then days 2 through 5. And a complete response was basically none of any of these things. The dexamethasone arm was superior clinically and statistically on day 1, with almost double, 70 or over double, 70% versus 30%, and days 2 through 5, 53% versus 18%, and then overall as well. So a pretty profound difference between dex added and placebo. Side effect-wise, no changes in deterioration of those with diabetes and no increased problems with glucose tolerance overall. This is a patient group that is not well served. They're seen primarily by interventional radiology or hepatology, and often an oncology pharmacist doesn't really see them. They kind of float through the system without good support from either clinic pharmacists or the inpatient pharmacist. Really questionable access to us. This is something that is really easy to add if you use electronic health records to add to their embolization order set some of these antiemetics, and then they just need follow-up for discharge. So I think this could be a significant boon if we can add this on to patients' care. The next poster was a phase 2 looking at minocycline for fatigue. These are non-small cell lung cancer patients getting chemo radiation therapy, and they're randomized to either minocycline 100 milligrams twice a day or placebo twice a day for the full duration of their chemo radiation, which was somewhere between 6.5 and 7 weeks. Looking at the groups, no changes in demographics between them. Therapy was similar, and baseline scores were similar when they looked at fatigue. The MD Anderson symptom inventory was used to measure fatigue. This was a 40-patient study with 19 receiving the minocycline and 21 getting placebo. They took that symptom inventory and created what they called an area under the curve for fatigue. And when you look at the minocycline group, it was significantly less. So overall, the duration of their chemo radiation, they reported less fatigue, and this is patient-reported outcomes, versus those in the placebo group. Grade 1 through 3 events were similar between groups, including those of radiation side effects. So this is a small study. It's phase 2. There's a lot we don't know about this, but this is a clear unmet need. We still really don't have anything for fatigue other than stimulants, which don't really always help. We don't really understand the mechanism, the biomarkers for the fatigue. Is this clinically as well as statistically significant? The area under the curve for fatigue, I think, is still kind of a new phenomenon and maybe not all that well explored, but this was well tolerated. And I was really struck by the fact that even though tetracyclines have sun exposure issues, the radiation here, there was no change in side effects. So this is, I think, that will be explored further and really could provide some benefit for patients. The next poster, loratadine versus naproxen versus nothing for pegfilgrastim-related bone pain. Something we all struggle with in the clinic. This was a randomized phase 2 of prophylactic naproxen at 500 milligrams twice a day, loratadine at 10 milligrams once a day, or nothing for 5 days, being on the first day of the pegfilgrastim dosing. 600 patient population, primarily Caucasian, and they did it for 4 consecutive chemotherapy cycles. Primary endpoint was all the different grades of bone pain. Let's see if I can get the slide to advance. There we go. The pain, all grades, and grades 3, 4 were comparable between groups. There was no statistical difference. You see some numerical difference with a trend towards lower pain in naproxen and loratadine arms. The adverse events, mostly GI, not too unexpected with naproxen, very low in the loratadine, and really no adverse events in the placebo group. Fewest patients actually just in the active treatment arms were discontinued with loratadine. This is an underpowered study. I think it won't change current practice. I don't think we're going to see more naproxen group. I think we use mostly loratadine in these patients. And as I looked at the lack of outcome, I was struck by the fact that here you have naproxen at significant doses, 500 BID, which should give analgesia, yet loratadine had the same outcomes. So while I don't know what it is, I think there's something going on here, and I don't think this will change our practice, which is actually to use loratadine as a low-cost, low-morbidity intervention in these patients. Romiplastim for the chemo-induced thrombocytopenia is our next poster. This is a phase 2 single-site study, open-label, 23 patients. These are all solid tumor patients who had platelets less than 100,000 for 4 weeks, and it had resulted in either a delay or reduction of the chemotherapy dose. Crossover from the observation group was allowed. The primary objective was getting the platelets above 100,000 within 3 weeks of starting the romiplastim. Treatment group was 15, 8 in the OBS group, about half were female. Mean age was around 56. Standard dosing with weekly titration of the drug. 22 overall received the intervention. 15 from the initial group, all of them did, and then 7 out of 8 crossed over from the observation group. Of these 22, 16 were then rechallenged with chemotherapy. When we look at the treatment arm, 14 out of 15 had platelets correct within 3 weeks versus only 1 in 8 out of the observation group. That's the one that didn't cross over. Of the crossover patients, 1 was not available for review, but 6 out of 6 that were crossed over and made the goal of 100,000 within 3 weeks. And actually the observation arm was dropped after interim analysis of this study. 16 of them got additional therapy and tolerated it, with 10 of those being the treatment group, 6 of the OBS patients, so all of the OBS actually, for at least 2 additional cycles without having a recurrence of thrombocytopenia. 4 were on the drug for over 12 months. There were increased thromboembolisms, 1 PE and 1 cath VTE, and no other grade 3, 4 adverse events attributed to the drug. Dosing, really unclear. They didn't really give a median dose. They didn't talk about really very well the time to response. So I think that needs to be clarified. The 100,000 is at the correct goal. 50,000 seems like more what we would look at. It could be they wanted 100,000 so they didn't drop below when they hit their nadir, but it's unclear. Would this be reimbursable? I'm not so sure currently. There's a phase 3 planned. But this is an unmet need, and I think it's interesting. Leucovorin for pralatrexate side effects is our next poster. This is a retrospective, single-center review of patients treated with pralatrexate for a 4-year period, all cutaneous or peripheral lymphoma patients that had at least 1 dose of pralatrexate by definition. Turned out they had a mean of 7 with a range of 2 to 18. And this is just 24 hours of leucovorin at 50 orally every 6 hours, starting on the 2nd day, approximately 24 hours after the drug had been dosed. 34-patient study, 24 without leucovorin, 13 with. 3 of them actually did cross over from the not getting the drugs to glucagon group after cycle 1. Mucositis was significantly released from decreased from 47 down to 17%. No change in skin effects, and importantly, no change in tumor outcomes. So the question that, while this is a small study, these are rare tumors, should this be standard of care? I checked with our lymphoma oncologist who treats these patients, and he said he's actually been doing this for a couple of years based on prior data he'd seen at a meeting. So I think this is something you will see. I think it's a potential benefit for these patients who are getting the pralatrexate. Prevention of everolimus mouth sores with dexamethasone mouthwash. This is one of the most interesting posters this year. Phase 2 single-arm study in postmenopausal women with HER2-positive breast treated with everolimus and exemestane. This is a common side effect. mTOR inhibitor-associated stomatitis, or MIAS as it's called. It happens in almost 90% of patients. It's generally within the first 8 weeks of therapy and has really significant effects on both adherence and quality of life. Bolero 2 study, which is this is going to be compared to, so this is a single-arm study. This is another study they'll be comparing to. Had 69% overall stomatitis, 30% grade 2, 8% grade 3, and this is kind of what they were targeting. The regimen is 25 of exemestane and 10 of everolimus daily, 28-day cycles. Starting on day 1, they did an intervention of dexamethasone mouthwash. This is an alcohol-free product, half milligram per 5 ml. They switched it for 2 minutes and then spit it out 4 times a day for at least the first 2 cycles, with an additional 2 that were optional. They needed to be NPO for an hour after each swish and spit. And since this is oral steroids, they did have the option of an anti-candidal regimen where they could do nystatin suspension 4 times a day, swish and spit once again, after that 1-hour NPO period. So that could get kind of onerous. Self-reported oral pain and diet via diary. They weren't allowed to have any baseline stomatitis. They couldn't be on other antineoplastics, and no additional corticosteroids were allowed. 92 patients enrolled, 86 evaluable, median of 61 years old, 62% Caucasian, primarily ECOG 0 to 1, and almost a quarter of them actually used the nystatin prophylaxis. The MIAS at 8 weeks, it was 21.4% with 2.4% grade 2, no grade 3 or 4. When you compare that to Bolero 2, clear benefit from the confidence intervals. There were 2 cases of candidiasis in those 86 patients. And if you look at adherence, it was great. 95% had a median of 3.95 doses per day. So really most people, even though it's a 4 times a day intervention, were able to sustain that. And actually at greater than 70% were on all 3 drugs at 8 weeks. When we look at adverse events, the main reasons they stopped drug or interrupted it were rash. There was some stomatitis breakthrough and some hyperglycemia, so somebody's swallowing, I think, some of that steroid. This is, I think, is ready for prime time. I think you will see this used with this regimen. The stomatitis is a significant problem in these patients, and I would expect to see this. The next poster looked at a rare group, acute leukemia in pregnancy. This is a single center, long study, 50-plus years. And they had 23 pregnant patients that had an acute leukemia during their pregnancy, 14 AML, 4 APL, acute promyelocytic leukemia, and 5 ALLs. 10 were first trimester, 7 second, 6 third. 11 of these patients ended up getting either elective or spontaneous abortions. 18 of them were able to get complete remission with treatment. Those who delayed therapy, over 1 week from diagnosis, half of them died. So this was a highly mortal decision to delay therapy. Those who received chemotherapy, there were 11 while pregnant. 2 of them were in the first trimester, 6 in the second, 3 in the third. It led to 4 fetal losses, which was all the first trimester kiddos, and then there were 7 deliveries. Majority of neonates were low birth weight. There was 1 mild anemia, and most importantly, no congenital malformations. Overall, at 55 months, 7 patients out of these 23, a third, were alive. Practice implications, first trimester diagnosis, I think, is a highly lethal event for the fetus. Later trimester treatment can be safe, and no congenital malformations is quite encouraging. However, I think the bottom line is that the mother actually has limited time to make a treatment decision because of the high mortality that was seen in this study. The next three posters are really med therapy management. How do we keep patients on these medications, and how do we manage them to get the most benefit? Post-hoc analysis of idelalisib, 1,000 patient plus for 5 different study or group of malignancies, 4 different ones. 51% experienced increased LFTs, either AST or ALT or both, and the median onset was at 5.6 weeks. Greater than grade 3 was seen in 14%, once again median at 5.6. Time to resolution a little over 3 weeks. No difference whether this was the drug alone or with other agents. All patients were managed with dose interruption and a re-challenge when they got less than or equal to grade 1. 70% had no event recurrence at re-challenge. 95% who had event recurrence had it resolved with no lasting hepatic effects. So this really supports the product guidance that you can interrupt and then re-challenge and keep patients on these drugs. I think from practice implications, the work that pharmacists do with oral oncolytics, with stopping, adjusting, changing medication, restarting after monitoring, really pays off for these patients and really allows us to optimize medications and prevents the need to change therapy. So this is, I think, real reinforcement for the benefit of things that we do. The next two are actually pharmacist-presented posters showing pharmacists can get posters into ASCO. This is CLL looking at ibrutinib dosing. 420 milligrams a day is your normal dose, and that, but per product information, greater than 2.5 mg per kg per day is needed to get at least 90% or greater of the Bruton's tyrosine kinase occupancy. This is a multi-center retrospective review of patients who were dosed at less than 420, the standard dose, within 3 months of initiation. Took 197 patients. 160 were at the normal dose. 37 were dosed at the some lower dose. Median dose overall was 4.3 mg per kg per day. A very small group were less than that critical 2.5 mg per kg per day. And 5% of them were actually on a CYP3A4 inhibitor, which could have resulted in higher ibrutinib levels in those patients. Most patients who had been reduced were dose reduced for GI or cardiac toxicity, bleeding, rash, or renal insufficiency. Primary endpoint here was progression-free survival. Advance there. Here we go. Best overall response rate was 85% at full dose, 84% at reduced dose. Median progression-free survival was 37 months. Overall survival actually had not been reached. So the bottom line is dose reduction, which was necessary for patient toxicity, and as long as it maintained above 2.5 mg per kg per day, it appeared to work. I think there's maybe an additional confirmation whether or not the less than 2.5 mg per kg per day is too low. It would be interesting to know, could we stratify by toxicity profile? Those that were adjusted for bleeding, for rash, for GI toxicity, does it make a difference? And is there a weight-based minimum dose here where if we have to go below it, we know that we're going to have to go ahead and change to a different agent to get benefit? And once again, looking at how pharmacists need to manage these medications. The final poster here is oncolytic adherence and confidence in managing side effects. 8-site study looking at an online survey over a couple months in 2015 for patients who had been on drug over 1 month. Demographics, health literacy, patient activation and confidence, and side effect management and adherence were all being assessed. 125 patients, mean age is 66, a little over half female, primarily Caucasian. The high activation score, which is involvement in their therapy, when higher, was associated with more confidence in managing fatigue, nausea, and diarrhea. So the more involved the patient is, the more benefit they had. Also, higher health literacy was associated with confidence, especially with fatigue and diarrhea management. So when I think about this, and I'm looking at who we have to target, about a third of them reported non-adherence, with those experiencing side effects and those at a shorter duration of therapy more likely to be non-adherent. Practice implications, easy 3-item test for health literacy to identify those with issues. Will education improve it? And I'm not sure exactly what education is the best for improving health literacy, but if we're going to target those, I think we should do those that I think most sites do, which is the first 3 months of therapy, and those with more adverse events really need more follow-up. A few tweets, just like Jocelyn had here. The first biosimilar for therapeutic intervention, trastuzumab, is likely to come, if it can get through the courts, in the next year or so. But EU and US trastuzumab was considered to the biosimilar. The PK, and then both response rate and immunogenicity in 2 different abstracts were really similar. And so that one is likely to be coming to us. Budesonide at standard cabazitaxel dose did not change diarrhea rates. Possibly the lower dose that Jocelyn mentioned may be a benefit here. There's no correlation between vitamin D levels and aromatase inhibitor arthralgias. There's been multiple papers on this, and I think the bottom line is it doesn't appear to make a difference on what their vitamin D level is. Receptor polymorphisms are probably the next thing that are going to be looked at. With the PARP inhibitor, olaparib, often used in combination with letrozole and anastrozole tamoxifen, no significant drug interactions. Those are safe combos. Trabectedin in liver compromise, there's a poster that looked at the PK with those with hepatic compromise, and with a dose reduction in mild hepatic compromise, looks like we may be able to dose this drug safely. Moderate to severe was confirmed as do not do. Single-day dex is as good as 3 days of dexamethasone when used with aprepitant for highly emetogenic chemo. This was another Japanese study, but for those that don't tolerate dexamethasone, this is maybe a great intervention, 1 day versus 3. And finally, pazopanib 600 milligram with food had equivalent PK to 800 milligram fasted. So here's a chance to 25% less drug with food appears to be the same as more. Moving to our first ARS questions, and if you want to have other questions, please feel free to type them in at this point. So a patient AA arrives with chemotherapy for chemo and expresses concerns about multiple side effects with their antiemetics. After reviewing the regimen, you feel that based on the recent evidence that you just heard, following changes can be made without affecting antiemetic efficacy. So A, to decrease the dose of olanzapine from 10 to 5, bump up the Zofran from 24 oral to 32 IV, change the dex to day 1 only, A and C, all the above. And looking at, we are now closing the poll here, and the majority did go with A and C. So based on that last little tweet, you could go with 1 daily as opposed to 3 days of dex, as well as the lower dose of olanzapine, which appears to be beneficial. This final question, when adjusting the idelalisib for hepatic enzyme abnormalities, it is best to A, hold when the enzymes are greater than or equal to grade 2, re-challenge when less than grade 1, hold when they're greater than or equal to grade 2, but do not re-challenge if they were ever greater than 3 or equal to 3, hold when they're greater than or equal to 3, re-challenge when they're less than grade 1, hold when the bilirubin is greater than 2, regardless of enzyme, and re-challenge grade 2. And closing the poll, yep, everybody got, well, almost everybody got C, and it is grade 3 that you, or the same or higher that you hold at, and then it's less than or equal to grade 1 when you restart. So there's the benefit, once again, of our med management strategies. And this is a complete list of the abstracts that I just did. I tend to truncate the titles because they're so long I can't fit them on the slides. So we're open for questions now. If you have them, feel free to type them in on your screen. We have a question here. What is considered grade 3 hepatic side effects? Oh, I knew somebody was going to ask this. So I do not have the CTC memorized. The key, though, on this, when you're looking at it, is the bilirubin was irrelevant. We're really looking at liver function test abnormalities, and I'm thinking grade 3 is greater than 5 times the upper level of normal, but I'd actually have to look that up. I didn't memorize that one. think we may have another question coming in here. The question is, do you use the patient's norm or your lab's norm? And this is an extension of that same question when we're looking at the drug and the management of their LFTs. You're actually using your lab's norm. The patient norm, if somebody is starting out with abnormal LFTs, that's actually going to be somewhat of a judgment call whether you actually use the drug. If they're greater than 5 times the upper level of normal to begin with, you got to question whether you can use full dose in that patient. So you're going with whatever your normal lab is, and the fact that an outside lab might be off by a few points on the AST or ALT, I think is irrelevant as long as you're looking at that and then comparing apples to apples, so to speak. We might be having one more question coming in. Somebody out there is helping me. Thank you so much. So based on the CAE version 4, upper level normal for grade 3 ASC is greater than 5 to 20 times upper level normal. So my guess was in the ballpark, greater than 5. So between 5 and 20. If you're over 20 times the upper level of normal, then that's going to be a grade 4, which is really bad. Thank you, Allison. Saves me. So actually, I'm gonna throw in one question since we're having a quiet point. Say, Jocelyn, on that last one, the myeloma abstract. So when you were talking about the European data versus the ASCO, so it sounds like one interchanged lenalidomide for bortezomib. Were the outcomes similar?
They were. The progression-free survival the hazard ratio that was noted in that study was also very low, in the range of the upper 0.3 range. So very similar trial as far as inclusion criteria and study design, and so they really kind of mirror each other when you look at the data, and the outcomes are very similar as well. So I think you could go with either one.
Okay, yeah, I could see in patients with neuropathy possibly going to the lenalidomide-based versus a bortezomib-based.
Absolutely.
Looks like there's another question for you on daratumumab. I'm going to punt that one to you.
Daratumumab, any idea on the mechanism of thrombocytopenia? I don't have any idea as to if it's actually contributing to thrombocytopenia. The mechanism of daratumumab itself is sort of, there's one of many mechanisms in terms of how it's attacking a multiple myeloma cell. I think there's a chance it is causing some thrombocytopenia, but I think more so in the Kastorf study, it's more due to patients being on therapy longer, and more probably likely due to the bortezomib over a longer period of time.
Yeah, that was my interpretation as well. More Bortez dose intensity.
And again, considering we're giving it on an intense regimen of twice weekly, every three weeks.
Did the European study, or the one reported in Europe, was that a once-weekly Bortez dose?
So just to clarify, the comparator arm was lenalidomide and dexamethasone alone.
Oh, that's right. So, okay.
So, but they did do once-weekly dexamethasone dosing in that trial.
Got it. I'm seeing no more questions.
Yes, if we have no more questions, we can conclude today's webinar. Thank you, everyone, for joining us. Thank you, Joe and Jocelyn.
Hope everybody has a good day.
Thank you, everyone.